So hello everyone, and thank you so much for joining me here on Faces of Digital Health for a discussion on remote patient monitoring, especially in Africa and in different settings around the world. I was initially contacted by the Clinitouch team. So Bruce Adams, I will give the word to you to tell us who else is with us here today. We've got clinicians, we've got your partners, so we really can dig into very deeply into the discussion from various perspectives.
Thank you, Tiasa. So, yes, I'm Bruce Adams. I'm the Managing Director here at Clinitouch, a platform with its roots in the UK NHS, but that over the last couple of years has been expanding across the globe. So we have partners and projects now across 5 continents, and a really big focus on expanding this technology through the Commonwealth in partnership with the UK government. Thoroughly delighted to be joined by a couple of our partners today to talk about their experiences with this technology on the ground and where it fits, but I'll let them do their own introductions. So, Dr. Jongh, would you like to go first?
Hello, my name is Dr. Jongh Adesioye. I am an anesthesia-trained pain and interventional spine specialist. I am the CEO of Utopian Consulting LLC, a healthcare business advisory firm that does majority of its work in Nigeria, and we represent Clinitouch in Nigeria.
Thank you, John. And then we've got Liam. Liam, do you want to go next?
So my name is Liam van Rooyen. I'm one of the Clinitouch system support managers here in South Africa. I work for Japie, Jongh and Synaxon, and I am responsible for a lot of the operations management of patient-client interactions on the application, and I work very closely with Japie to make sure Clinitouch is a success in South Africa.
Okay, thank you. And Japie?
Hi everybody, my name is Japie de Jong. I'm head of a tech company here in Pretoria, South Africa. I'm not sure if you can hear my voice well. I've got a bit of a slow feed or a low feed on the audio. So we have a collaboration with Clinitouch. We've been collaborating for the last 12 months or so in commercial projects, and we are very excited about the project. We've got early outcomes on the data. It looks very promising, and certainly very, very positive on the project, and very excited to share some of the conversations with you, what we're doing, and share maybe some of the results.
Okay, awesome. Thank you, Japie. Bruce, if we start with you. So you work in very different contexts in relates to remote patient monitoring. Remote patient monitoring is something that we like to talk about in very different contexts. There's virtual wards in the UK. There's a clear need to monitor chronic patients remotely, so we don't just get snapshot of their health and get a broader picture of how they're doing, or to make it easier to interact with them. So how is Clinitouch looking at this topic? How do you see that remote patient monitoring has been evolving over years? And where would you say we are today when we talk about remote patient monitoring?
Thank you, Tiasa. So there is hugely different applications of remote patient monitoring that varies both within country, within regions within country, and also across continents. So yes, you're completely right. The remote patient monitoring drive in the UK, especially over the last 2 years, has been slightly more high acute and in creating more capacity within hospitals both in a step up and step down perspective. But when we look at the large health economic benefits of remote patient monitoring, it is in managing long-term chronic conditions, and that is our core passion. Where I believe Clinitouch has been successful over the last couple of years as we've started to internationalize our technology is in not trying to pick up a UK model and drop it into other countries. We went on a big drive to identify, recruit, coach, mentor local partners, two of which you see on the call today. And we are very much driven by their experience on the ground and where remote patient monitoring, such as Clinitouch, delivers the highest health economic benefit for the populations within those countries. We do see more commonality across continents than we do differences, but that doesn't mean that local nuance isn't important. But essentially, for us, the area where remote patient monitoring has the most impact is in the management and proactive management of long-term chronic conditions. Yes, it has other applications, but where this can make a big difference is in that space.
Mm-hmm. Okay, thank you, Bruce. So if we move to Jongh, who's based in Nigeria, and Japie, who is in South Africa, can you talk a little bit more about the context there? So we know that in many African countries and contexts, what healthcare is strong at is regional and community care, where nurses do a lot of work. So the nursing workforce is quite strong. So who does remote patient monitoring in your case? Which disease areas do you cover? And are we talking mostly about higher end patients, so patients that are more wealthy? So let's just start with that, and maybe Jongh, you can start with Nigeria.
Thanks, Yasa. Basically, as far as Nigeria is concerned, remote patient monitoring is a bit of a new phenomenon, if I can put it that way. And a lot of this has translated from the COVID period, in which people had to basically get care and not needing to go into a healthcare facility or wanting to go into a healthcare facility. So that has basically kicked off the use of technology in healthcare. So in our situation, we use remote patient monitoring to collect data from patients, mostly in remote areas, in communities, and in their homes, and basically transmit this to their healthcare providers. And the healthcare providers vary depending on the setting. In some situations, it's the clinicians themselves who actually collect this data from the patients. At times, it's caseworkers that work for things like insurance companies or for other entities that maybe geriatricians that basically look after all the patients in their homes. And they just have, a hub of people that actually look after those patients from time to time. So it varies depending on who the provider is or what the setting is, whether it's a clinician, whether it's a hospital itself, or an insurance company. And the need varies from clinical conditions. In this setting, we think the best use of it will be in chronic conditions, just like Bruce said, and in monitoring these patients who, for the most part, for various reasons, don't either need to or want to come into a healthcare facility. And we think based on that, the use of remote patient monitoring is actually very, very applicable in this setting. You mentioned community. In a lot of places, we don't have doctors and nurses. We use community healthcare workers. So these can collect the information or be the contact person for these informations, and they can use whatever they get to decide who actually needs to see a nurse or contact a nurse or contact a healthcare provider, and so on and so forth. So that's pretty much the way we see it in this environment.
Mm-hmm. Japie, what's the situation in South Africa? And maybe just to add to that, I know that in Africa there's not a lot of doctors. The ratio, between doctors and patients is really, really low. So to which extent is, if it is, remote patient monitoring addressing the need for workforce? How is it impacting the care delivery in terms of accessibility?
Oh, nice. Thanks, Tasha. I hope you can hear me well.
We can.
Yeah, the South African setup, we got a split system. We got the private sector and we got the public sector. The private sector consists of plus minus 12,000 GPs in South Africa. We got a very specialized network of physicians, specialists, and a very good hospital infrastructure. I think our private healthcare really very much on standard in terms of world standards. I think our public sector are very similar. Our public sector cater for people that are uninsured. So they go to the public facilities. It breaks down on various levels. We've got entry-level facilities, which is just a clinic where there's normally, just like you said, nurse physicians. And then we got larger public facilities like what we call the CHC, community healthcare clinics. They're large facilities. They consist of doctors, primary physicians, occupational healthcare. So we got a proper, in South Africa, very deep-rooted, proper quality healthcare system. Of course, many people are deprived from private healthcare. So we are ultimately with Spirit Health and Clinitouch, we want to focus on the holistic potential of the program. We started off with the public sector, with the private sector. In South Africa, we call it health insurance. People buy their insurance, they pay monthly for their insurance, and for the insurance, they get a card very similar to an NHS, and with this card, they can access care. They can access care on various levels. So traditionally, the patient monitoring or the virtual ward is not a big focus in South Africa currently. It's an emerging market. I think we are ahead of the curve with Spirit and with Clinitouch. I think with being ahead of the curve, there's certain big opportunities, but there's also obviously certain barriers to entry. So your question in terms of what kind of patient we're currently looking at. So currently we're looking at the medical aid scheme patient. There's plus minus 13 million of those patients in South Africa, of our population of around about 60 million people. There are various medical aid schemes with various options, with various benefits. What we've selected to do is to focus on the chronic cohort, patients on chronic disease, specifically patients with a high risk and a very high risk. What that basically means is it's a patient that is compromised on a chronic condition. In South Africa, we got 26 registered chronic conditions, and we're focusing on them basically on a professional basis. So we've started with hypertension and ischemic heart disease, and we've expanded to sugar diabetes, and eventually we will get to other specialized illnesses. So your question in terms of the patient, so these patients vary from option, scheme, and plan. It might be entry-level options on a medical aid scheme to very advanced options, depending on what the patient is willing to pay monthly. It's an insurance model. It's not a national health insurance model like in the UK, but we are also making progress towards that kind of model. And once again, therefore, we think the virtual platform very appropriate, and we'll deal with some of the examples. So I'm not sure if I addressed you well.
Yes, you did. And actually, I have like 5 follow-up questions for that, for others as well. One thing that you kind of got me thinking when you started explaining a lot, on which patients do you focus on and how do you work is, and I think this is a question that Bruce might be best to answer. What we see currently, so in October 2024 in the US, is this huge uncertainty around how telemedicine is going to be covered up until now because of the pandemic, especially for mental health. Clinicians were able to prescribe prescribe medications to patients even if they didn't see them. And now that's probably going to change. So there is going to have to be an in-person visit before you prescribe medications to patients. And Bruce, I just wanted to ask you if you could put in context remote patient monitoring and telemedicine. They kind of go together. At the same time, they're not exactly the same thing. So how do you differentiate between the two, especially in the context of countries that you work in?
So first and foremost, I suppose, Chasa, is you use the US example, and what's really important, we have a saying here in the UK, but we apply it globally, is that you need to follow the funding. So you've ultimately got to understand who will foot the bill for the remote patient monitoring. Now that varies across the world. So we have countries like India, and many countries across Africa where there's a lot of out-of-pocket payments. But but in many countries as well, we work with the health insurers themselves, because the downstream healthcare savings are so significant for health insurers if we can prevent people coming into hospital and into clinics and keep people at home. The patients are happier, etc., etc. To answer specifically to your question around remote patient monitoring and telemedicine and where the two about where the crossover is essentially, I don't think there's a clear delineation, but where we tend to draw the line is that Clinitouch is very much a tool to support clinicians to make a clinical and treatment decision. So we are in the game of gathering data, both PROMs and PREMs and holistic type data, and then vital signs data, in order to identify where treatment may be required. And that's provided through to the doctors, so that then the doctors can make that treatment decision and target their very valuable and sometimes limited resource in the most appropriate way. Now, Clinitouch is a tool, has a video consultation functionality built into it, so that can support then that treatment conversation remotely, and that's where the lines start to become a little bit blurred. But we do have requests sometimes for medication management, functionality within the platform for it to feed automatically into pharmacies for dispensing and etc., etc. However, we like to very much keep within the realm of data gathering and patient engagement. It is far harder than people appreciate to engage patients, to engage clinicians, and to build a tool that people actually use. So let's be honest. If people don't use it, then there's no value in the software whatsoever. So we very much focus on what we would say in our wheelhouse in making that data gathering process and risk identification as seamless as possible. The treatment and what we would traditionally call telemedicine arm of it is a different arm of the industry. However, we very much see this as being a tool that supports clinicians to make those treatment decisions themselves.
Okay. Thank you, Bruce. So, Liam, when we talk about remote patient monitoring, there's technology that's involved in making sure that you can provide it as a healthcare provider. So what kind of challenges do you see that the customers struggle with most often? What are kind of the support issues that you get addressed with a lot? So I think it's very interesting to kind of unveil that a little bit, because when we talk about, mobile healthcare and using remote patient monitoring, it's easy to imagine how it works in the ideal scenario. However, there's issues with lack of connectivity, with the type of devices, with many other things. So I'm wondering what you see can be kind of mentioned here.
So, very good question, actually. A lot of the stuff that we see these days, or when I go out to clinics, when we go out to clinics, we try to onboard patients, is device compatibility. Obviously, I believe the Clinitouch software doesn't run on, or the application doesn't run on specifically Huawei devices due to underlying political issues with these, with the app stores and whatnot. So a lot of patients that are older will have older phones, older software on their phones, older operating software that don't necessarily allow for the application to be loaded. Barring that, it's more so the age of the patient, but it's also it's a specific type of person more so than the age itself, because you get 80-year-old people who can work the app flawlessly, and then you get some 63-year-old people who don't know how to set date ranges and whatever for support purposes. Good example would be recently a patient asked to have their app reactivated because they got a new phone. Sent them all the details and whatnot. This patient is 65 going on 66 years old, and he was unable to do the remote activation himself on the application because he didn't understand the way that the user interface worked. Whereas we have other patients who are 70 going on 80 years old who manage it just fine. So a lot of it, I think, is to do more with how you orientate the patient. So when we do an onboarding session with a patient, I'm normally there directly in front of them, explaining how the app works. So if they have any questions, they can ask it and see how it works there and then. That's what we found works the best with these individuals, because the remote here, I think maybe it's due to our lack of tech savviness, maybe in the older generations, but at this stage it is more the user interface issues, that kind of stuff.
Mm-hmm. Okay, awesome. Thank you. Jongh, do you have anything to add to that from your perspective? What do you see in Nigeria? How do customers see, the technology that they need to use? And maybe you can think beyond, Clinitouch and also other technologies that are used in Nigeria for your patients.
I think with technology as a whole, the first thing is trust in what you're trying to get them to do with the technology. And a lot of people look beyond, okay, is this going to collect more than my healthcare data? Are we looking at something else here? So you have to convince them that the technology is basically geared to what it's supposed to do, nothing outside of that. And then you have, reliability issues. When you put in a new app on a phone, you have people that have got, like Liam said, old phones, and you now have to say, okay, how reliable is the phone in the first instance that you're actually, inputting the technology on. So apart from that, there's the cost. Some people use regular phones that may not be data capable. Now you want them to use an app, download an app on a phone that actually uses data, which for them, they only use for WhatsApp and nothing else. It's supposed to be strictly for entertainment. And now it's supposed to help monitor their health and their conditions. So that at times is a concern, trying to convince them that certain things are, required for, their health and wellness. There's this skepticism, and then there's the fact that, there are local situations in which you have different, network providers that are more amenable to the use of certain apps than others. So all these things we have to leapfrog to make sure this works. Again, when you try to, explain it to the patient, is the fact that it's something that's been used in the UK. Their first reluctance is, okay, how does that translate to what we're trying to do here? So I have to explain to them that it doesn't matter whether you're in Nigeria, in the UK, hypertension is hypertension anywhere in the world. So it's heart failure. So if those in the UK deserve to be monitored remotely, so do people in Nigeria. So there's a lot of, conversations around all that, including the fact that at times some people have power issues, and they'll say, we haven't had power for, a month and a half, and, diesel is expensive. I've just decided to just leave my device for now till, power is more, affordable and accessible and available. And that may be beyond when they need to give you information on their data. So there are numerous things that we have to leapfrog in, trying to make this work. But the convenience of the fact that, you can just get your information to your doctors right there and then in your house at times makes it worth going through what a lot of people see as the trouble of dealing with remote patient monitoring. That, okay, I don't have to go to the hospital every month. It can be once every 6 months. And then they remember that it does cost them money to go into the hospital and things like that. So they look at it from different perspectives, and you have to balance what the concerns are based on each individual, patient. But on the whole, with technology, it's, the same issues. In certain parts of the country, they're limited, data transmission. They don't have so many coverage with cell phone towers. You have to take that into consideration and say, okay, I will send somebody to collect the information who doesn't necessarily reside in your locality that has the restrictions, but they collect the data when they get to their part of the state or their part of the country that has better connectivity. Then they can transmit this information off to the physician. So you have to find ways to leapfrog the different challenges that comes up with different individual patients, because they're usually never the same.
Okay. Japie, do you have anything to add to that, particularly in around the topic of how do patients feel about technology that's basically brought in from abroad? On the one hand, all smartphones are not locally made, more or less. So all the big brands that we use on a daily basis, we are used for that to not be local technology. And at the same time, even when it comes to software, a lot of it in Africa is also imported. So are there any questions or concerns that people might have around who the provider is, or just, the general attitude towards this?
Yeah, no, look, I think we were well received, right? I think the tech is actually amazing. I think it's quite elegant. We as a tech company has been working with remote solutions for many years. The cell phone is just the pinnacle of remote access. So in South Africa, the electronic record's been going very strong for donkey years, but this is really a real proper introduction to patient involvement, because all the previous exercises in South Africa really didn't involve the patient. And I must say, I'm actually very impressed with the Clinitouch design. Simple, it's elegant, it works in any phone. I mean, there are one or two phones where there's problems where Liam expanded on it, but 90%, 99%, 95%, I must check. Patients on board, all of a sudden you got a different view of the patient. You never had that view of the patient before. The clinicians had to wait for the patient to deteriorate. They see it basically on the app. There's two sides of the app. Obviously the patient portal and the provider portal, just that one understands it. Things very, very nice, very effective, very elegant software. The first population we put up was more than 250 patients on hypertension on the first pilot we've done. I was amazed to see how we got that data coming in. And I was also pretty impressed to see how the data flags on the dashboard, not only for us, the coordinated care team, but very specific also for the provider, because it's really about the provider. It's making the provider, the world of the provider is now augmented with rich clinical data. And it empowers the provider to make decisions on the fly and faster. So I think Spirit Health did a marvelous job with the tech. I saw it, and when I saw it, I loved it, and I still today like it more. I think it's easy. It's making a very complicated topic on the phone very easy. It's well thought out. It makes provision for customization around the various diseases. So we've set up and customized it for the South African market around hypertension, ischemic heart disease. And we are busy customizing it for the South African market around sugar diabetes. It's wonderful just to work with an international outfit. It's fast, it's effective. We have our weekly checks in with them. Their tech team comes back. The process flows, the business analytics is first class, a triple A. The problems that we have is obviously introduction to market, right? It's a brand new product. In South Africa, I suppose, like all around the world, there's quite a lot of cell phone fraud. So our most difficult thing is just to get the patient to know we are legit. And when we phone the patient, the first time they're a bit skeptical, they want access to my phone. But we had many examples and opportunities to re-engineer how we engage with the patient the first time. And since we got that right, how we engage with the patient and consent with the patient and the medical aid schemes that we're working with, we just tweak the consent a bit. So then the patient know, oh, okay, we're from ABC or we're from DEF, we're from their medical aid scheme, and then it's pretty straightforward. So I don't think that's our stumbling block at the moment. Our access to patients are there. The patients enjoy it. The providers love it because they're seeing the outcome and how quickly they can intervene on a patient. What we're busy doing at the moment is getting the financial model right? Because remember, when you ask the patient to participate, no problem. But behind the patient sits his or her physician or his or her doctor. And it's not a free service. Those doctors need to be paid for the service that they provide. And like I said, we focus on the high and very high risk patients. And I think we've done wonderful work with Spirit and Clinitouch on getting the reimbursement model right, because that's really what we're busy with at the moment, to get the reimbursement model right. And obviously there are barriers in the reimbursement model. It's the Clinitouch system, it's the medical aid scheme administrator, the claim needs to arrive there. There's co-operability involved in getting all the data up and down between the various role players. But I think we've done a wonderful job where we are, and I'm pretty excited where we are. I know it's taking a bit longer than we thought, but what's good about what we're doing is we're building the infrastructure on the back. The intellectual model is there. We're just moving it up to be interoperable with our systems and with the medical aid scheme or the pay office system. You need to get the provider paid. That's basically what I'm trying to say.
Thank you, Japie. Bruce and Liam, when we talk about partnerships and collaborations, as Japie just mentioned, the need to integrate with different applications, the need for data to flow, how do you look at potential partners or vendors that you're going to work with to integrate data? So Bruce, from your perspective, you're basically looking at companies that are going to be sort of your distributors or new customers, and Liam, you I guess have a different perspective because you really need to look at different solutions that then need to kind of work together to get the maximum out of all the data that patients are gathering. So, Bruce, do you want to start?
Yeah, so from a new partner perspective, the first, and I would genuinely say the most important thing for us is cultural fit. So we obsess about culture here at Clinitouch, and also that our vision is to make healthcare accessible, affordable and easy for all. And we genuinely want this technology in the hands of millions of patients around the world in future. So we want people who share our vision and are a good cultural fit for us. In line with that, and hopefully you've seen that on the call with John and Japie and Liam today, is a passion for the difference that digital healthcare can make. It isn't easy just at times. There's hurdles to overcome. There's challenges. We've heard quite a few of them today. So you need that passion in your heart that this will make a big difference. It will achieve the mission and the goal, which is ultimately to improve improve patient lives and access to healthcare. If I get down to a little bit more of almost operational stuff, almost. So from our experience, we know the NHS really, really well. We're very well connected. We've been doing this almost 15 years now in the UK. And we have the network. So when we have a wild and wonderful new idea, or we see a new application for remote patient monitoring, there's people we can go and talk to. There's places we can go and pilot it. There's et cetera, et cetera. So we also look for within our partners to have that network to be able to go and test and trial and essentially to collaborate within their territories with organisations to figure out how to fit Clinitouch into the market. That peer-to-peer support is super important as well. So that network is really, really important to us, and also a real willingness to learn from us. So, but learning is a two-way thing. So as I said, we've been doing this a large number of years. So we have a great deal of experience from how to deploy this technology and how to deploy it well. However, our partners have the local expertise in their specific health economies in where to fit this and how to make this work. So that passion for shared learning, both between us and our partners, but also really importantly between our partners themselves. So what's absolutely fantastic, and Jongh and Japie might not know this yet, but Jongh and Japie will be together in Cape Town at a community event next week with us, where the goal will be to share some of the challenges, share the opportunities, share the wins, and learn from each other essentially as to how we can bring this technology into new markets. So, and that's where the cultural fit is really important to us. We can't put Japie and Jongh in a room and have them, not knocking two bells out of each other, so to speak, and not be willing to come on calls like this and to share their expertise. And so yeah, that cultural fit is really key to that shared learning and that shared experience.
Absolutely. Liam, what would you have to say to that, from your perspective when it comes to partnerships and collaborations to kind of connect even other providers potentially for remote patient monitoring? And one thing that caught my attention earlier when Japie was talking was that a lot of cell phone fraud happens. So can you maybe just explain what kind of fraud patients are basically threatened by?
Yeah, so in terms of cell phone fraud, everything from scam calls to account fraud and stuff happens here quite frequently, unfortunately. So a lot of the issues that I've dealt with personally phoning patients at clinics would be they assume immediately when they see the number that it's associated with their clinician or with their practice that they regularly go to. They assume it's to do with something with payment. So they're already not really on a good foot with it. They don't really want to pick up the cell phone. It's more so then getting through and then explaining the whole process to the patient and really selling what we're trying to do here to the individual. And we find that the minute they kind of understand what's going on, that it's not scam, it's not fraud, it's not anybody looking for money or anything like that. They're very open to the idea actually of coming onto the project. So that form of collaboration is very important. As Bruce pointed out, the cultural differences and everything between the NHS model, the South African model, I'm sure the Nigerian model as well, is they're probably quite big, the differences. But what we found here is a lot of the collaboration is to do with identifying exactly where the patient's from, so the areas where they're living, what the medical aid scheme has on these patients, what their interactions with the medical aid scheme is with, and then using the good points in all of those to really drive it home. So a lot of the stuff we do at local practices, we know that their primary point of contact or the people that will be more likely to collaborate with are their local doctors. We don't want to go in and then pull patients into the wrong practices because we've identified them on the sheets. that collaboration is something that has to be very specific. From the provider's perspective, fortunately, Japie's got, I think, every major scheme on speed dial here. So a lot of the stuff that we do, we can just pick up the phone and then ask, this is what we've got, this is what we want to do. We've stratified the risk, we've identified patients, this is what we want to do with them, and this is why we want to put them on the program. From there, it becomes more collaboration between us and the doctors, be it specialists, treating GPs, anything like that. And they are quite forthcoming, I think, after we take them through, because we like to take them through a very detailed look at what the program is, what it offers their practice, and generally it's very, very good compared to the alternatives in the country. That offers them a very comprehensive look at the patients, offers them a very comprehensive look at what they're doing with the patients, how the patients are responding, what they can do with the patients, and just updating medical history, adding notes, just keeping tabs on everything. So collaboration is one of the key points there.
Well, thank you everyone, for sharing all the insights. There's definitely a lot of challenges that can be addressed with technology, and you are helping with some of that with remote patient monitoring. And good luck with all your future collaborations, and enjoy the community event. Those kinds of knowledge exchange are definitely valuable for everyone.
Thank you, Charles.